Thank you for this invitation. Thank you for the nice introduction. And I'd like to take you onto a journey over the past 30 years of how a new neurometabolic disease developed and what we learned during these 30 years of work on Glut1 deficiency syndrome. There has been an international consensus published last year, which I'm going to address, from 23 experts. And there are future challenges that we're still struggling with understanding the disease, making treatment better for the children. And so let me start that journey. Now, here is, I'll start with the past, telling you about the history of how this novel disease emerged, where there was a very simple mechanism, a very simple diagnostic tool, a very simple means of treatment, and very successful means of treatment. And then in the present, we learned that things can be much more complicated as numbers of patients increase. And now, of course, we are looking into the future perspective. So you can see that on the bar on the left-hand side, the green bar. It all started with the man you can see on the right-hand corner. It's Professor De Vivo. He's about 80 years now, and he's a child neurologist, an expert on cerebral energy metabolism. And in 1991, he had 2 children, and these children had epilepsy. And when he did a lumbar puncture, he recognized that there was low CSF glucose. Now, what made him think of a novel disease was that the glucose wasn't low because it was used by the brain. It was low because it didn't enter the brain. And the clue to that was that the CSF lactate, which is usually a sign that the brain is starving or can't use glucose like a mitochondrial disease, was low to normal. So that wasn't the problem. And then there was this Glut1 transporter described as the blood-brain barrier, and that made him think, well, maybe this is a novel disease. And then he found a young scientist in Germany, which was me at the time, and I met him in Munich, and we talked about that. And he said, don't you want to come in my lab and work on that? And I did, as you see here. So this is a concept. The brain works on glucose. It's the basic fuel for the brain, and it enters the brain via the bloodstream. Here is the glucose from your meal, and it will cross the blood-brain barrier and go into the brain to feed it. And this is done by a transporter called Glut1. And as you can see here, it feeds the brain cells. Now, if this transporter is broken, you have low CSF glucose. And what you can do is you can offer a ketogenic diet, and then via a different transport mechanism, you can enter ketones as an alternative fuel. But what you're actually doing is you're running the engine with a different fuel. You're using gas instead of petrol. And that makes the brain work again because it's got enough energy again. So that was straightforward. And then there was a lumbar puncture, as I just said, which showed you this low CSF glucose and the lactate, which was low to normal. And of course, when the gene was identified, we found several mutations in the gene. They were mostly de novo, and it's an autosomal dominant disease. We know about hotspots, sort of certain cluster of mutations, and that helped to diagnose the disease too. And then, of course, there was a symptom. So you had these 3 features. You had the low CSF glucose, you had a characteristic clinical presentation, and you had the gene. And if you had that, you were very sure you had this novel disease. So that sounded very easy. And so was our understanding of what this energy crisis in brain causes. It caused epilepsy, a movement disorder, and cognitive behavioral distances. And there's a classical phenotype. You had everything, but sometimes you only had 2 out of the 3 items. So that was easy to understand too. And now we introduced the ketogenic diet as an alternative fuel for brain metabolism. As you can see here in a split screen, you can see on the left-hand side the patient, how he was before he got the ketogenic diet. On the right-hand side, 11 months on the ketogenic diet. And I think the difference is really striking. And you can see, especially here with the gait, how much it improved once the brain got enough energy again. So here we go. And then it got complicated. Why? Because we found that the story wasn't that easy at all. We found much more presentations of the disease. We found variants, we found unclear results, and I'd like to walk you through that. The problem is when you only have 2 out of these 3 characteristic features present, what do? So if you have a patient that has clear symptoms of Glut1 and he has a mutation but he doesn't have low CSF glucose, or he had a mutation but didn't have CSF glucose, do you call that Glut1 deficiency or do you not? And that was a problem. So symptoms missing, borderline CSF glucose, mutations with unclear significance. What do you call that? Is that a disease or isn't it? Then we found that there were clinical presentations along the way. Some patients just had stroke, some had reversible low CSF glucose, some had just a funny sort of epilepsy. So the clinical presentation was highly complex and variable too. Then we found out that the clinical features change over time. So a baby would have completely different set of problems compared to late childhood, adolescence, or early adulthood. So as you see here, the epilepsy really is a problem of infancy and early childhood. But then in adolescence and in adults, it's not really the big problem. The problem in these patients is the movement disorder, which is ataxia and dystonia. So you can see that the clinical presentation changes over time, and we had to understand that. Then we learned that these patients had sudden attacks of movement disorders. We call that paroxysmal events. And when we did the questionnaire, we asked 73 families, do you know that? Do you experience that? They said 3 out of 4 that yes, we do. And basically, it was movement or muscle tone, speech, and attention affected too. And the striking finding was that it increased over age. So in infant, it wasn't really that present, but in adolescence, it became really present. And I'll show you a video in a minute how to see how that looks. So over time, we saw that the first presentation were funny eyes, seizures, developmental delay, then became apparent. Then there was a movement disorder with these paroxysmal events. And then there were atypical presentations like migraine, Vitus cramp, or alternative hemiplegia. So we had to make sense out of that. And then we found out that the ketogenic diet is not just one ketogenic diet. As probably most of you know, now we are talking about ketogenic diet therapies because we have a classical diet, we have a modified Atkins diet, which is MAD, we have a low glycemic index treatment. So we had to vary that over age too. Then we had the first adults with Glut1 deficiency, and they had, again, very interesting findings we didn't see in the children, like basal ganglia abnormalities, as you can see here. We did find that previously in the PET studies, where you can see here it's the same problem at the same place, but it was difficult to interpret, and again, it seems to be a problem of adults. So here comes one of our co-workers, friends, and well established in the metabolic, in the ketogenic field. It's Professor Eric Kosek from Johns Hopkins University, Baltimore, and he dropped me an email and said, "Hey Jörg, you see all these things, random thought on a Sunday afternoon. Shouldn't we do a consensus?" So we decided, we started on a questionnaire, and we got 13 experts. We sent out a questionnaire. And then we had a meeting and we met experts. You can see Dr. DeVivo standing here in the middle, and you can see Eric here, you can see myself, and a lot of other people who tried to make sense out of this complexity of this novel disease and bring up a consensus statement. And then so we had the questionnaire, we had the experts, we wanted to add a state-of-the-art section so that everyone who reads that paper can see where we stand in the year 2020. And of course, there was a lot of work, and I was quite busy with it. And it was meant to be finished in 2 years ago in 2019 when we had the Washington Glut1 meeting. And I got emails, where's the paper? Well, eventually we did develop the paper. It's published now, and it's in Epilepsy Open. So everyone can download the full paper and can get the state of the art of what these 23 experts think how to recognize, diagnose, and treat this condition, and also what the perspectives are. And this is, of course, the future, which will be the final part of my talk. Now, I'd like to carry you through this consensus very briefly and show you, basically by showing you videos of these patients and the problems they have, because I think that's much more informative. The consensus wasn't all agreement. We had controversies, and these controversies were all over the field. We discussed the clinical presentation, we discussed which diagnosis is the best and how do you rank them, what do you do if parts of the diagnostic tools don't work. We talked about the treatment, which ketogenic diet, alternative treatments, anticonvulsant medication, and so forth. And then, of course, the research and future perspectives, which I'll come to later during the talk. Now, this is the scheme you saw before, where you had the three diagnostic tools. You have the lumbar puncture, you have the clinical symptoms, and you have the mutations in the Glut1 gene. And as you can see, if all of these three are positive, of course, it's Glut1, and it's a confirmed Glut1. But we did decide that even if you have low CSF glucose and the mutation, and even if you don't have any symptoms yet, like babies or relatives within a family pedigree, we still call it Glut1 deficiency. And again, we ranked the CSF glucose higher than the genetics. So if you have a clear-cut low CSF glucose and you have a characteristic symptoms, it is Glut1 deficiency. Why? Because with the mutations, we do have variants which we call of unclear significance. These are mutations that might not cause the disease. They might be there, but they don't cause any trouble. So the mere presence of a mutation in itself might be non-disease causing, and as such, we decided that if you have other variations like that, we call it probable Glut1 deficiency, and of course, if none of them are present, it is not Glut1 deficiency. Now here we go. This is the very, very first impression, sort of the clinical symptom of Glut1 deficiency. And these are babies that have funny eye-head movements, and they are paroxysmal, meaning sudden. And I'll show you a video where you can, oops, sorry, video doesn't work. We tried it before. Oops, let me try again. Yeah, here we go. So here we go. So this is a 5-month-old girl, and she's not having a seizure. She's attentive, she's looking at mom, but you can see that she can't control her eyes. They go sort of back and forth, and the head is moving accordingly. And this was told to us by the parents, and we knew that this is happening, but it took some time until we understood that this is a characteristic symptom of this disease of Glut1 deficiency. Now then, early absence epilepsy. Absences are sort of sudden and brief cessation in activity, and they rapidly return to normal, so sometimes it's very easy to miss. You have a characteristic EEG pattern, and if it's happening under the age of 4 years, then in 10%, at least this is published in this very good paper in neurology, they might be Glut1 deficiency. So in every child that has an absence epilepsy, an early onset under the age of 4, you should look for this condition. Now the epilepsy can not only be the absences, but also staring spells and myoclonic static epilepsy, meaning these children have myoclonic jerks and sometimes loss of posture and tone, and this is shown by this girl. She's on a ketogenic diet, she's having breakfast, and what you can see there, that she now will have an absence. You can see that suddenly she stops, her behavior arrests, she has a sort of staring spell, probably not reactive. Now it's over, and you think, okay, everything is fine. And then there you can see that she has this myoclonic jerk, which is clearly an epileptic seizure. Now she's returning to her meal. Here you can see again, she's having this absence, doesn't react properly and has another myoclonic jerk. Here we go. So if that happens 20, 30, 40 times a day, of course, this is very disturbing and disabling, and it needs the ketogenic diet to get rid of it. Now, this is German children, and this boy was brought to me because the parents said this was the video when I understood that something is wrong with my boy. And let me play to you. The sister is elder, she is healthy, but you can see that he is sort of having a wobbling, broad-based gait. He needs the hand of his sister to walk. He can't walk fast, he can't run fast. And parents said, now this is abnormal, we need to see a doctor and find out what the problem of this child is. And it was Glut1 deficiency syndrome. And when they grow older, parents describe this movement disorder as a drunken gait appearance. And this is very nicely shown in this video here. You can see that he is having this ataxic, dystonic gait. He's asked to walk as fast as he can. And as you can clearly see, he can't. And he has got this funny posturing of his arms. And that's pretty characteristic of Glut1 deficiency in school-age children. Again, you can see the right arm is very funnily postured. This is dystonia. And then he has dysmetria, meaning he has this finger ataxia. He can't really do these pointing maneuvers. He can't stand on one leg at the age of 6 or 7 years. So that is clearly abnormal. He has microcephaly, as you can see there. And as you can see in a second, he'll be asked to walk on a straight line. And you can clearly see this gait again, which is very ataxic, wobbly, unsecure, hypertonic ataxic with dystonic posturing of his arms. Okay, so this is a 13-year-old British girl, and she has what we described as these paroxysmal sudden attacks of movement abnormalities. Now she has Glut1 deficiency. She's on a ketogenic diet, and now she's asked to walk. She has good ketosis, and as you can see here, she's almost perfectly normal. You wouldn't guess that she has a problem. So treatment is working. And then if she was shopping in the winter time, and this is in the hotel lobby, after shopping in the cold for some hours, you can see that she has this distressed movements. She can't stop them, she can't regulate them. It's causing her distress. She needs mom to comfort her. And these lasted about 20 minutes without being controlled, and eventually rests, then stops these attacks. So these are what we call these paroxysmal exertion-induced dystonias. There's a new clue to Glut1 deficiency, which was just published half a year ago, and it's called what we say crisscross gait. And let me just play that video to you. Maybe you've seen that. This is an adult, and what they do is they have funny walks, and they are often mistaken as being a psychiatric disease or sort of just fooling around, but they are not. They can't control that. It comes often paroxysmal, meaning sudden, triggered by fasting or by physical exercise. And what happens is that you have the legs that sort of go crisscross, and the upper body is trying to compensate for this imbalance. Okay, now I think we have a third patient in this video. And as I said, this is brand new, that it's just been published, and we need to look for that. Okay, now how about treatment? We do have ketogenic diets, not just the one classical ketogenic diet, 4-to-1, 3-to-1, as it's depicted here. We have the modified Atkins, we have low glycemic index. The MCT diet would be up here, and then of course a regular diet. And the advantage of this sort of ketogenic diet light is that the taste is better. It's easier to get compliance from the patients, but the ketosis is lower. So What's the right diet in GLUT1 deficiency? In infants, we would always recommend that they go for a 3-to-1 ketogenic diet. The 4-to-1 can't be done in infants and usually can't be done in adults. So this is really for maybe school-aged children. In GLUT1 deficiency, we try to get a high as ketosis as possibly can be. Modified Atkins usually is not used in infants, can be used, but basically it's for adolescents and adults, and the low glycemic doesn't really produce enough ketosis to be an alternative fuel, so we do not recommend that in the consensus so far. Do the patients stick to that? Of course not. As you can see here, and this has been published 2016, in seizure there are about 100 patients, 92 patients with GLUT1 deficiency, and you can see that, well, 60% used the classical ketogenic diet and 1/3 used the modified Atkins. In Japan, there was a nationwide survey at the same year in 2016, and you can see here 40 patients, and it's quite the opposite. Most of them are on the modified Atkins diet. Interestingly, the seizure control is the same, but the question is, do they provide enough energy for the developing brain? Maybe in the long run, it's better to keep the ketosis as high as possible to avoid long-term effects. This is quite interesting, as you can see here in the year 2021. If you use the data bank Medline and you enter GLUT1 deficiency or ketogenic diet, it's been constantly going up. So there are a lot of people interested in this disease, and we learn more and more about it as time goes by. And we do look for side effects of the ketogenic diet. Here we looked in 10 patients with GLUT1 deficiency for 10 years. And what was quite encouraging is that the cholesterol and the triglycerides stayed the same before and after 10 years of treatment. And compared to a control group, the ultrasound of the carotid arteries was normal too in the GLUT1 patients. So this is encouraging. Of course, it needs more data on that. Okay, so let me spend the second part of my talk on the future. What are the challenges? It now sounds like a great concept. You have a very effective ketogenic diet treatment, but what are the problems and what are the things we haven't understood in this disease? Now, of course, we don't have just one glucose transporter in brain. We have several ones. You can see here, now we have about 14, and they all work in concert. And we haven't understood how this concept works in you and me, in people unaffected of GLUT1, and we haven't understood at all how it works if one of these transporters is abnormal, as in GLUT1 deficiency. Of course, we are not alone in on this planet. There has been a report on another sugar transporter, PACE-A, which is important for the brain. It's restricted to the brain, exclusively expressed in certain areas of the brain, and soon enough we had to find the deficiency, and that was published in 2017. Dysfunction of the cerebral glucose transporter SLC45A1. And interestingly, these individuals have the same clinical features like GLUT1 deficiency, intellectual disability, and epilepsy. So it is a differential diagnosis to GLUT1 deficiency. It's a different genetics. It's not autosomal dominant, but recessive, but it does cause intellectual impairment and epilepsy. So it's the second cerebral glucose transporter we need to think of in addition to GLUT1. And sometimes maybe if it isn't GLUT1, but the features are right, then we need to look at it. Also, there's another disease called PURA, and there's a PURA gene, and it causes low CSF glucose. So it's a differential diagnosis when you have a patient with low CSF glucose, and it's not GLUT1, it might be PURA. And they found that GLUT1 could be downregulated in this scenario in the peripheral blood cells, and they proposed GLUT1 as a new PURA target. Now, what is PURA? Let me just show that to you. It is a neurodevelopmental disorder characterized by intellectual disability, epilepsy, feeding difficulties, neonatal hypertonia, and interestingly, the ketogenic diet does not work in these patients. So here we have another neurological disease where we have hypoglycemia, low CSF glucose, and we have to consider that as a differential diagnosis if the ketogenic diet fails to help these patients. We learned a lot about the transporter. Here you can see very nice pictures of the three-dimensional way this transporter works. It works like a latch. So the sugar, here comes the sugar, and the sugar then enters the transporter through a pore, and then the transporter gets recycled. So that's a very nice concept, and you can see that some of these features of these models, you can put in the mutations we identified in Glut1 patients, and you can see why the mutations cause, for instance, the glucose pore not to work properly. So that was very interesting. And just last year, there was another very nice paper showing that it's not only one transporter, but it's 4 transporters working together. They call it an oligomer. So basically what you have is, in a normal Glut1, 4 of these transporters work together. And if you have mutations, these 4 don't work together anymore as a functional unit. You have misfoldings, you have aggregation, and you have Glut1 deficiency. What we don't know is, we've learned a lot about genetics, but we don't know what's happening in the cell. So in order to produce the glucose transporter, you need a gene who tells you the blueprint, and then you need to translate that into a protein, and that protein needs to be processed, needs to be folded, needs to be activated, needs to be sent to the membrane. So all these steps can be a problem if you have Glut1 deficiency, and for the moment it's a black box for us. We do know that we can protect the transporter in avoiding alcohol, caffeine, green tea, and some anti-epileptic drugs. Now, I hope I have the time to briefly take you on a very small trip, because we know something about the trafficking and activation. And this was published in 2018 in one of the best journals of the world, Cell, with a very, very high reputation. And they described Glut1 deficiency. And they described something they call the D-leucine motif. Now, let me briefly explain you in a cartoon of what happened. If you produce a product in a factory, right? You put 2 things together and out comes a product, let's say a toothbrush or whatever. And in order to send this product to its destination, you need a label. You need a label that sort of tells you to go there. If that label is wrong, the transport will send your product, the toothpaste or toothbrush, not into the shop, but somewhere else, to the junkyard, for instance. So workers will then process these wrongly and then maybe discard that without even reaching the shop. And the same happens in this Glut1 D-leucine motif. It's a mistrafficking. So you have the gene, and then the Glut1 has a tag, and this tag is the D-leucine motif. And if this tag is wrong, then this transporter won't reach the membrane in order to work in the brain, but will be sent somewhere else where vesicles will swallow them up, and then eventually it will be digested and disabled. So it'll never reach its destination. And that is a very complicated but very intriguing mechanism how a patient could have Glut1 deficiency. And it's always a great achievement if you could explain that to the very patient. Maybe there are drugs available who could block that so that the tag will be there, but it won't be read and won't be misplaced. So these are prospects we are hoping for. Same holds true for the diagnostic tools. We have Glut1, we have a red blood cell assay which detects Glut1 on the red blood cell. And this is an antibody. And if whenever the antibody detects the Glut1 molecule, it starts to emit light. And the light can then be counted, and then you can see maybe it's Glut1 or not. Right? The problem is that it will only detect quantitative Glut1 deficiency syndromes, meaning patients that have maybe 50% of the transporters on the membrane. The patients that have all the transporters there, but they have a functional defect where the transporter is present but not working properly, will be missed by that assay, and that's the problem. We also know that we look for mutations in the genes, but we now identified variants in untranslated regions of the genes that then change sort of the coding, and the Glut1 will be truncated and it will be non-functional. And that's just been published too by our group. Now, what about other tissues? If you think of Glut1, we always focus on the brain, but maybe it's not just the brain in these patients. Maybe other tissues are dependent on Glut1 too, like the muscles, retina, placenta, and heart. And so far, we are at the very beginning of understanding the role of Glut1 deficiency in these other organs. Maybe because it's then an adult problem or a problem of old age. Now, what about alternatives for the diet? Can we use oral ketones? Can we use ketone esters rather than a ketogenic diet? Now, do they work? Do they produce ketosis? Yes, they do. You can see here that this is a publication where 15 healthy volunteers took this salt, which are oral ketones, or a liquid, which is ketone esters. And as you can see here, they did achieve ketosis around 1, 2, 3 3-hydroxybutyrate millimolar. This is actually what we measure to control Glut1, to control ketosis in the blood. You can see that the ketose esters were quite powerful in achieving ketosis. So were the salts at a lower level, and after 3 hours or 4 hours, it was gone again. So that's the problem. You can't replace a ketogenic diet by these oral ketones or ketone esters because you need a lot of these, which will not be digestible or eatable, but especially by children, and the half-life will be quite short. But there are options, and we are following that through. There has been a study with one of C7, which is an artificial sort of ketone esters, but unfortunately the study did not achieve any of the endpoints it wanted to achieve, so it was stopped. Does that mean 3-heptanoin is not an option at all? No, because maybe you need a different study design to try again, and there are other studies on the way looking at the combination of 3-heptanoin with ketogenic diets in Glut1 deficiency, but we don't have results of that yet. Gene therapy, of course, would be the answer to the problem. The mechanism is that you load a virus with the Glut1 gene, then inject it into a mouse, and out comes a normal mouse. And that has been proven to work in Glut1 deficient mice. Unfortunately, not taken any further yet. That was presented by Dr. De Vivo again in 2016 in the first Glut1 meeting in Milan. And the same group also found that one of the main problems in Glut1 deficiency is that the brain vessels are not growing well enough. And that causes a mismatch between the cells, the brain cells talking to each other. So what they did is they took this Glut1 mouse, they did gene therapy on the mouse, and then looked at the vessels again. You can see that they were much better. They're much bigger, they're much larger, and of course, because the Glut1 was working again, the cells were working again too. Okay, now this is brand new. This is from October 2020. This is a Japanese group, and they took onto a pig, and they used the same virus promoter and looked whether the pig will produce more glucose transporters, and in fact it did. So there's a lot happening in this field. We try to understand the phenotype, the clinical presentation, by entering all the patients we identify in a registry, as you can see here, run by Professor Pasquale in Dallas. So here you can again see the challenge from the baby up to the adult and adolescents. We need to find the correct diet, we need to find the right diagnosis, we need to understand the clinical features and see if we find alternative treatments to the ketogenic diet or additional treatments. The speech is a big problem, also to life quality. I'll come to that. Unfortunately, here you can't hear the sound, so I'll skip these videos. But let me, if you're interested, if I got you interested in this entity, or you have patients, you can then join the online meeting, the third European Glut1 meeting in June in France. You could always, sorry, also do the online meeting in June with the American Glut1 Deficiency Foundation group, and then in October in the UK, in Brighton, there will be this big 7th Global Symposium on 100 years of the ketogenic diet. Professor Helen Cross from Great Ormond Street is the mastermind behind that, and you're warmly invited. They'll talk about every aspect of the ketogenic diets, from sports to nutrition to epilepsy to metabolism to gene therapy, everything. So I hope I gave you a brief run through 30 years of how it started, how we define it at the moment, state of the art, which is the consensus paper, and the challenges and the perspectives I covered in my last slide. So here are the families, here are the kids, and here are support groups we rely on to understand this disease and help us get better. In that way, thank you very much for your attention and open to questions.